Welcome to In Cancer TV, and we are here in Paris during the 13th International Myeloma Workshop, and I am very happy to be with Professor San Miguel from Salamanca, Professor Sonneveld from Erasmus University Rotterdam, and Professor Ludwig from Vienna. So there are several new issues that came up in this meeting, and let's start from the treatment of older patients who are not eligible for high-dose therapy. Professor San Miguel, do you believe that we have a definitive answer that a triple combination should be the choice, or we are waiting more trials to decide regarding the best appropriate treatment for these patients?
Okay, I think this is a very important question. In most of the trials with the novel agents has been based on triple combinations, and they have shown that they are more effective than the conventional melphalan-prednisone. Nevertheless, this data with bortezomib, thalidomide, and lenalidomide in the triple combination is currently being challenged by the data with len-dex. And I think probably these are the two options: len-dex until progression, or MPB or MPT for a fixed period of time, and then you have the opportunity to retreat. But there is also emerging data about the possibility of using a sort of maintenance after, for instance, MPB. The data presented both by the Italian and the Spanish group indicate that now you can achieve PFS of around 3 years with this approach that is a more soft induction and then a maintenance period.
Professor Sonneveld, do you believe that we can get rid of melphalan in the treatment of these patients? Do we need more data? There were some comments this morning that melphalan is probably of no use anymore.
Yeah, well, I think in Europe, melphalan has always been the mainstay of myeloma treatment, especially in the elderly, at conventional dose and at high dose for the younger patients. I know that in the United States this is less common, and people with the availability of lenalidomide have now more often chosen the option of lenalidomide dex, as was mentioned by my colleague Dr. San Miguel. But in my view, melphalan is still one of the most active drugs in multiple myeloma and should not be discarded easily. As we in our country will certainly not do so.
Professor Ludwig, you published actually on this issue that melphalan-prednisone is superior to thalidomide dexamethasone. What are your views regarding the role of melphalan?
I would second what Pieter Sonneveld has just expressed. Melphalan is an important drug in myeloma. It is a drug which is suitable for patients who have, let's say, low-risk disease, and it's an excellent combination partner for novel drugs. So I think also we have some new drugs available, like bortezomib and lenalidomide and thalidomide. I think melphalan is still an important combination partner, and we shouldn't give it up unless we have something which will substitute it. And there are drugs on the horizon, but at the time being, I think we should retain the drug within our treatment armamentarium.
Let me tell you a story.
Yeah.
I saw a patient, she was the mother, a very old lady, the mother of an ophthalmologist from the United States, and she failed all the treatments in the United States and came to Spain just to die. And I reviewed all the drugs, and I realized that she had not received melphalan. I treated her with melphalan, and she responded, and she enjoyed a very good quality of life during the response period. Then I think it's a drug that should be maintained in the armamentarium because it's an effective drug.
Absolutely.
So why don't we ask our moderator, how is the situation in Greece?
I think that melphalan-prednisone is included in the currently approved regimens, which is MPT or MPV. And let me get to a more difficult question. Professor San Miguel, there are some colleagues who support a risk-adapted approach for older patients with myeloma. Others may suggest that you should give the most effective treatment to standard risk patients, because in these patients you may have higher response rate, and this may translate to a longer survival. What is your approach?
My approach is that I will use a soft treatment for the very elderly patients, the patients with high comorbidities.
No, for
those that the expectancy of life,
okay,
whatever you use, is very short. And I will try to avoid additional cost and the inconvenience of treatment. For fit patients, elderly patients, I think I should try to do all my best. So I will not, the best possible treatment should be particularly used in the standard group.
Okay, so you are supporting the view that even in standard risk myeloma we should give you know, the best possible combination.
Yeah, I think we should reduce the treatment when we are able to cure the patients or to achieve really, really a prolonged survival. Yes. Nowadays, I think we should try to improve.
Professor Sonneveld, there were some opinions this morning that a complete response may not be of significant value in older patients with standard risk myeloma. What is your opinion about the importance of complete response in this patient population?
Well, yes and no. I mean, in the high-risk patients, I think for all the patients we should still try to achieve a complete response, because this provides them with the opportunity for prolonged survival. But I have to admit that there is a certain number of patients that have less aggressive myeloma, and in those patients they do well if they achieve a PR or maybe a very good PR and remain stable for a couple of years. So in those patients, if you have no indications that they have aggressive myeloma, I would not pursue a CR at all costs, okay, but also look at the back side of the coin, which is toxicity. So treat them with as much as they need to achieve a prolonged survival.
Yeah. Professor Ludwig, you have done studies in the past regarding quality of life in patients with hematologic malignancy and myeloma. How you will define a frail patient for the practicing hematologist or oncologist in Europe?
That's a difficult question, because we now should distinguish between comorbidities and frailty. So comorbidities is easily said, because that is cardiac dysfunction, pulmonary dysfunction, renal dysfunction, and probably also liver dysfunction. But most importantly, and that is not addressed in most comorbidity indices, is bone marrow function. So that is something, that is the comorbidity. Frailty is something which is which represents or shows the patient's ability to cope with personal activities of daily life. And so it's less easy to graduate frailty, because it's, we don't have numbers here available, so we have to judge and we have to test the patient whether he is able to perform his daily activities. But it's an important prognostic factor, and the question is now how to integrate both frailty and comorbidity into a new system. And we have to accept that in myeloma we haven't used these morbidity indices and the frailty measurement, and we should introduce it as soon as possible. There is a hematological stem cell transplant index which has been used in some myeloma patients. It has been shown that, of course, comorbidity has an important impact on survival, so it's associated with survival.
By the way, I mean, there are some...
May
yes,
I comment
absolutely.
because I would also like to emphasize that frailty as such is not a reason per se not to treat. I remember a patient, 85 years old, in the nephrology department. I was asked as a hematologist to come and see the patient. It was an old man lying in a bed. He didn't do anything. He was clearly, he had to go to dialysis, or he had to decide to do nothing. So I decided to treat him with the low-dose VMP schedule, as you have developed. And 2 weeks later, this man walked out of the hospital, and he's still doing well. So this learned me also that if you treat those patients, the very frail, in a gentle way with a dose-adapted schedule, you may achieve significant clinical improvement.
Would you consider age above 75 by itself as a frailty parameter? Some colleagues propose that this is a sort of automatic
no, I don't think so. I don't think so. If you are talking about large numbers of patients, 75 is probably a cutoff. It can be used. It has clinical value. But we always perform a geriatric assessment of the patient, and this is more important, I think, than age.
I think we are all three clinicians, and we want to see the patient. Because I think to individualize the treatment is the most important issue in the elderly population.
Absolutely. It's the physiological age and not the chronological age, which is important for treatment decisions, but also the patient's perception, of course. That is, of course, the most important question in an elderly patient, whether he really wants to receive treatment. And if yes, then everything is clear for us.
And the family. Don't forget.
Because the family has to support him.
Yes, but of course, I always teach my associates, the patient is in our focus and not his family members. So
they have to be on the same line, but because they will support him, they will take care of the side effects.
Yes, but he has to give the answer.
Absolutely. So, Professor San Miguel, regarding the currently available strategies to use the novel agents, and especially bortezomib, in patients with comorbidities or with frail patients or with very old patients, what are your recommendations?
Okay.
How you would recommend to adjust bortezomib?
Bortezomib is a typical history of a learning curve on how to use a drug. And this is not the only one. In the past, we have demonstrated that bortezomib was an efficient drug, but associated with important toxicity. Now we have learned that if we move from the twice weekly to the weekly dose, we significantly reduce the toxicity. And on top of that, we know that if we use in sub-Q formulation, it's more convenient for the patient and probably is associated with less toxicity, and the efficacy is preserved. And probably the efficacy will be even higher because you can prolong the treatment. Then, once again, I mean, to adapt the treatment and to know how to handle the side effects will eventually return into a major benefit for the patients.
Okay, and to complete the non-transplant eligible patients, Professor Sonneveld, what are the future questions that you feel need to be addressed in this patient population?
Well, as several studies have shown, there's an enormous improvement in outcome by adding novel agents to MP, melphalan-prednisone. Both thalidomide, lenalidomide, Velcade, they all show an improvement in response, quality of response, progression-free survival, and in some cases also overall survival. So I will, at the present time, we have already achieved a lot for those patients, but there's room for improvement, significant room for improvement. And this might come from other agents that are now under clinical development that may be combined with any of the novel agents. And maybe if those are very successful and can be implemented in the clinic, we might think about reducing the conventional drugs like melphalan and dexamethasone. Not now, but maybe in the future.
Okay.